keep myself very brief and comprehensive, and I'll try to finish it in time. So, what is hypoglycemia? These are the different classification of hypoglycemia proposed by American Diabetes Association and by Canadian Diabetes Association. But in modern days, we use this classification of hypoglycemia that was proposed by American Diabetes Association that came in standard of care in medical in diabetes in 2017. According to this modern classification of hypoglycemia, we divide hypoglycemia into level 1, level 2 and level 3 hypoglycemia. What is level 1 hypoglycemia? When plasma glucose is less than 70 milligram per deciliter. Remember the word plasma glucose that we check it from laboratory. It's not the capillary glucose that we check from glucometer. If the plasma glucose is less than 70 milligram per deciliter, it is hypoglycemia alert or level 1 hypoglycemia. When it is less than 54 milligram per deciliter, it is clinically significant hypoglycemia. And any hypoglycemia that requires third-party assistance would be called as level 3 or severe hypoglycemia. So, do we need to investigate each and every person with hypoglycemia? The answer is no. We will investigate only those patients with hypoglycemia in whom Whipple's stride is documented. And what is Whipple's stride? Here you can see. When there are signs and symptoms of hypoglycemia, documented low blood glucose and the resolution of symptoms with normalization of blood glucose, this stride we call it as Whipple's stride. Any hypoglycemia meeting Whipple's stride would be an indication to evaluate further, to rule out the cause of hypoglycemia. So, if we discuss the pathophysiology and the counter-regulation of hypoglycemia in a normal individual, we see that there are 3 lines of defense against hypoglycemia in a normal individual. What is the first line? The first line of defense is, at the time of hypoglycemia, there is increased glucagon secretion. The second line of defense is the sympathetic overdrive to release adrenaline and non-adrenaline from adrenal medulla. And the third line of defense, it is the increased release of growth hormone and cortisol. All these lines of defense protect an individual from hypoglycemia. But this counter-regulation, this is impaired in patients with type 1 diabetes and in advanced type 2 diabetes. So defective counter-regulation of these stress hormones at the time of hypoglycemia can lead to catastrophe in these individuals. So, in different ways, hypoglycemia may induce pathological changes in cardiovascular system. On one side, it increases the sympathoadrenal response. On the other side, it causes endothelial dysfunction, inflammatory effects, and prothrombotic effects. So on one side, patients with hypoglycemia, they are at high risk to have coronary artery diseases. Right? On the other side, they can have lethal cardiac arrhythmias, and that is one of the most important cause of death in bed in these patients. So recurrent hypoglycemia over time, specifically in patients with type 1 diabetes and in advanced type 2 diabetes, with defective counter-regulation, end up with hypoglycemic associated autonomic failure. It will straight away lead to neuroglycopenic symptoms, and that is a real catastrophe in patients with hypoglycemia. I think we should skip this slide. This is the data I've taken from a landmark trial in type 1 diabetes. That was DCCT trial. According to this trial, you can see the lower the HbA1c, the more the chances of hypoglycemia in an individual, and vice versa. So here you can see the classification of symptoms of hypoglycemia by age. You can see the autonomic and neuroglycopenic symptoms. They are there in all ages. But the children, they have to face behavioral changes. In adults, there is non-specific malaise, and elderly individuals, they face these symptoms, the neurological symptoms in the form of visual disturbances in coordination and impaired balance. So the sign and symptoms of hypoglycemia you all know very well. They are because of sympathetic overactivation, and they then may be because of neuroglycopenia. So hypoglycemia affect an individual in different ways. On one side, it can cause cardiovascular side effects, cerebrovascular effects. On the other side, these patients, they have socio-economic and psychological impact, and these individuals, they are at high risk of death. So here you can see the morbidity in hypoglycemia is specifically because of the neurological effects, the cardiovascular effects, and the muscular skeletal effects in the form of falls and accidents. This is the CGM data. In this study you can see the many episodes of hypoglycemia. They are unrecognized. In a study, 63% of patients with type 1 diabetes and 47% of patients with type 2 diabetes, they had unrecognized hypoglycemia as measured by CGM, and 74% of all events, they occurred at night. In another study, 83% of hypoglycemic episodes detected by CGM, they were not detected in patients with type 2 diabetes. So what are the risk factors of hypoglycemia? You all know the advancing age, severe cognitive impairment, poor health knowledge, increasing HbA1c, hypoglycemia, unawareness, long-standing insulin therapy, renal impairment, and neuropathy. There are all the risk factors for hypoglycemia. What happens in patients with type 1 diabetes? What is the cause of hypoglycemia? There's so many causes of hypoglycemia in patients with diabetes, like incorrect insulin administration. Insulin, when not taken in relation to food or in relation to exercise, then insufficient exogenous carbs because of delayed or missed meal, then decreased endogenous glucose production in the form of in the cases of excess alcohol consumption, then increased utilization of carbs and increased insulin sensitivity because of exercise and because of rapid weight loss, and then delayed gastric emptying as a complication of gastroparesis, and obviously decreased insulin clearance in patients with advancing nephropathy. So these are the risk factors in patients with diabetes. So what is the etiology of hypoglycemia in adults? The hypoglycemia may be because of endogenous causes or may be because of exogenous causes. In endogenous causes, it may be because of insulin, or may have insulin independent effect to cause hypoglycemia. The insulin-mediated causes of hypoglycemia are the insulinoma, nesidioblastosis, insulin antibodies and reactive hypoglycemia. While insulin-independent causes of hypoglycemia, they are because of target organ and organ damage, because of septicemia, hormonal deficiency, and islet cell tumors. In exogenous causes, we have drugs, very important cause of hypoglycemia, drugs. Then factitious hypoglycemia, and then hypoglycemia because of alcohol intoxication. Another way to classify hypoglycemia, when we evaluate hypoglycemia, we see whether patient is ill or medicated, or whether patient seems well. These are the causes of hypoglycemia in ill and medicated individuals. They are drugs, critical illnesses, hormonal deficiency, and non-islet cell tumors. While in seemingly well individuals, Hypoglycemia may be because of insulinoma, nistidoblastosis, insulin antibodies. We do have convincing evidence of certain drugs to cause hypoglycemia, but we do not have convincing evidence for other drugs to cause hypoglycemia. Here you can see. So evaluation of hypoglycemia symptoms in adults without diabetes. Here we review all the glucose levels in past, and we see whether the glucose levels were measured through laboratory, that means venous plasma glucose levels. If the glucose level, they are more than 65 milligram per deciliter at the time of symptoms, it means the hypoglycemia as the cause of symptoms is unlikely. When it is less than 65 milligram per deciliter measured in laboratory, it means hypoglycemia is the disorder is there. So we have to evaluate that disorder. If the glucose levels were measured through glucometer and they were more than 80 milligram per deciliter at the time of symptoms, it means they are not because of hypoglycemia. And if they are less than 65 milligram per deciliter at the time of symptoms, it means the symptoms, they are because of hypoglycemia. And if these levels are between 65 to 79, obviously we further evaluate whether they are because of hypoglycemia or not. Evaluation of hypoglycemia in asymptomatic adults without diabetes. Here we measure only the plasma glucose in laboratory. If it is less than 40 milligram per deciliter, it means it is because of the disorder related to hypoglycemia, and we evaluate it. If the plasma glucose is more than 65 milligram per deciliter, it means it is less likely the cause. It is not the cause of the symptoms. If the venous glucose is between 40 to 65 milligram per deciliter, we further investigate. And if the age of patient is more than 40 years and the previous history suggests that patient has history of hypoglycemic symptoms in past that diminished over time, it means the hypoglycemia is there and we will evaluate it. So a busy slide to evaluate hypoglycemia in non-diabetic individuals. Let's open it up. So hypoglycemia, meeting the Whipple's triad, and we have obtained medical history, we have done physical examination, and we have reviewed the labs. And we see whether the hypoglycemia is fasting or prandial. Fasting hypoglycemia means if the hypoglycemia is there after 5 hours after meal. And prandial hypoglycemia, the hypoglycemia is within 5 hours of meal. We investigate both these kind of hypoglycemia in different ways. The fasting hypoglycemia, 5 hours after meal. We conduct supervised 72 hours fast, and we collect samples for insulin, proinsulin, C-peptide, antibodies, oral hypoglycemic secrete, when the plasma glucose level is less than 45 milligram per deciliter. So fasting hypoglycemia, meeting Whipple's triad, and we have done with supervised fast. Then we measure the plasma insulin. We see the plasma insulin. If at the time of hypoglycemia plasma insulin levels were low, the hypoglycemia may be because of ketosis, maybe because of prolonged exercise, alcohol, or maybe because of glycogen storage diseases. If insulin level, they're high, while C-peptide level are low, it means the hypoglycemia is because of exogenous insulin. If insulin levels are high at the time of hypoglycemia and C-peptide levels are also high, we do drug screen. If it is positive, then it's factitious hypoglycemia. If it is negative, and we check the antibodies. If antibodies are positive, then obviously it is because of autoimmunity. If antibodies are negative, obviously then it is insulinoma. In case of perennial hypoglycemia, what we do? We conduct mixed meal test, or the meal which has caused symptoms in that patient in past. We conduct a mixed meal test and we check all these parameters: insulin, C-peptide, proinsulin, and things like this after every 30 minutes for 5 hours. And what we will see, if there is no history of GI surgery, then the diagnosis will be nesidioblastosis, means the beta cell hypoplasia without apparent tumor. If there is history of GI surgery, we assess the pattern. If it is within 6 months after surgery, then we follow the algo of fasting hypoglycemia. And when we exclude perennial hypoglycemia, it is because of the bariatric surgery that we usually call it as reactive hypoglycemia. I think we should skip this slide. I'm going to finish my talk in 1 minute maximum. So how we are going to manage hypoglycemia? In cases of diabetes, when we come across diabetes and hypoglycemia, the management is only 2 words: prevention, education. Nothing more than that. So what we will do at the time of hypoglycemia, we apply rule of 15. We ask patient to take 15 gram of fast-acting carbs, and then we check blood sugar after 15 minutes. If blood sugar levels are more than 70 milligram per deciliter, it's fine. We give complex carbohydrate 15 gram. If it is again less than 70 milligram per deciliter, we repeat the step number 1, and so on. These are the examples of fast-acting carbohydrates, and these are the examples of complex carbohydrates. And so this is how we do, this is the last slide, how we manage hypoglycemia in symptomatic and asymptomatic individuals. We have done with this side in a patients who are conscious. While in unconscious patient, we give glucagon. We give glucagon and we check blood glucose after 15 minutes. If it is low, we repeat that step. If glucagon is not available, like in this part of world, we give 100 ml of 20% dextrose water and we repeat the same steps. And after correcting hypoglycemia, we evaluate the cause of hypoglycemia and we treat it. With this, I conclude my talk. Thank you very much for your patience.